Thank you all for being here today. Thank you, Andy, for the introduction. As Andy said, I'm Joan Thompson, and my co-presenter and I, Michael Mann, we are lead business analysts at the Cleveland Clinic. We work in enterprise business intelligence and report up in medical operations in our group and not through IT. So we feel that gives us a lot of flexibility in the way we do analytics and the type of work that we do, which is for the entire enterprise. Today, we're going to talk to you a little bit about the way we've implemented Tableau and the way we've used it with EPIC to help create better outcomes for our patients and help that reporting be disseminated throughout the enterprise. So first, a little bit about what we're going to talk about today. As I said, we're going to present some background information to you about our business challenges and our objectives. We'll talk about our overall analytical strategy, and then we're going to show you a couple of use cases. The first is about a partnership with emergency services and how partnered governance helped to drive self-service analytics in that department. Secondly, we're going to talk about a couple of strategic initiatives, one around patient access and another around clinical care paths. And then finally, we're going to see how our C-suite executives are using the flexibility of a Tableau Viz to collaborate with the medical specialty institute chairs to help drive performance and enterprise goals. We'll, of course, conclude with the benefits and next steps and take any questions you guys might have. All right, so let's start a little bit about the Cleveland Clinic. The clinic is the clinic has over 150 locations, both nationally and internationally. We see over 7 million patients a year. This is across all medical specialties, which we group into service lines that we call institutes. We are proud to be the #2 best hospital in the nation from U.S. World and News Report this year. We have over 3,000 physicians. We were founded in 1921, and I skipped ahead. We were founded in 1921 and have been physician-led since that time. And as I said, we have locations all over, but we're mostly in northern Ohio. We have over 13 hospitals and 15 family health centers. And as of just last week, all of our locations are on the same electronic medical record, and that is helping us to bring data from all our facilities together much more easily and consistently to drive reporting. Our overall mission has always been an emphasis on teamwork, collaboration, and the sharing of knowledge and resources. So this is emphasized by our 5 strategic goals or pillars. The first is patients first, continuously improving quality, safety, and the patient experience. The next is around our caregivers, who we feel are some of the best in the country and are dedicated to delivering world-class care. Secondly, affordability and being good stewards of our resources. We also promote growth within the organization from ourselves and with others to help drive the Cleveland Clinic's overall goals. And then finally, the impact of making a difference through research, education, and innovation. So that's a little bit about the Cleveland Clinic, its overall mission and its values. So let's talk a little bit about our implementation with EPIC and Tableau and some of the challenges we faced. Like many of you, we have multiple audiences, and we face similar challenges in trying to get the right data and the right analytics to the right person, since everyone has a different reporting need and a different ability to actually consume those analytics. So it can be quite easy with a cool reporting tool like Tableau to put out all kinds of fancy reports that, for a lot of times that works great for the statistician or the analyst, but when you get that up to an executive level, it really doesn't always meet that needs. And in the end, that ends up with underutilized reports that is frustrating for the end users as well as for those of us who create them when it seems like nobody's using them. This diverse level of user sophistication makes it even more important for us to really understand and do your due diligence in finding out what your user needs, what they're trying to accomplish, and also to remember that the way that our ability to create reports and the ability to consume those reports on the user side doesn't always grow at the same speed. As I said, we may be way up here and be able to create reports, but our users still haven't quite gotten there in terms of being able to understand and use those to their best ability. We have a really mature reporting environment currently that has over 60 dashboards and data marts, but we still receive over 200 ad hoc requests per month in our BI department. So it's really important that we make sure that we, like I said, get the right data out to the right people. Our overall objective is to get analytics out quicker. We want to lower the amount of time it takes to create visualizations and increase the number of creators. Yesterday, I saw Andrea Tull at Mass General, and she made a comment that I hadn't really heard before about you wanted people to work to the top of their license. And I guess what that means is, so if you're a physician, you want to work at a physician's level and be doing work that is in line with that physician's license. If you're an RN, they want you to work at the RN license. So everyone is getting the most value out of the person that you are. And we want to do that as a business analyst and a business analyst analytical team. We want to be able to use our trained business analysts to create the most complex and to dig into the data and put some really thought-provoking analytics together. So our hope is that driving toward more of a self-service model, which is what this is doing, it will help free us up as analysts to create some of that kind of data and to disseminate that out to the enterprise. The good thing is that we have full executive buy-in from the top down, and so being able to deploy Tableau out to our analysts in our institutes has been very helpful. It's a great way to empower our users as they become subject matter experts on not only their own data, but any other data sources that they are going to need to use to create their own analytics. So that brings us now to a discussion of our analytical strategy, and Michael's going to take over from there.
Great. Thanks, Joan. So as we look at the analytics strategy at Cleveland Clinic, let's look at the way that we view institutional alignment, which is a two-prong approach. On the left, you can see we have the commitment flow down, and on the right, we have our performance management tools. So as we look down the commitment flow down, we start at the very top at our enterprise goals or our strategic initiatives, framed by the 5 pillars that Joan spoke about earlier. And then as we go down each layer of the organization, we look into our service lines, into our institutes, or into our community hospitals. Then we further break it down into the department or even our frontline managers. And on the right-hand side, you see that we have performance management tools and analytics that align to each one of those layers in the commitment flow down. So at the enterprise level, we have our monthly executive review, which is a use case example that we'll show later in today's presentation. And we have our strategic initiative dashboards, 2 of which Joan's going to highlight upcoming. And again, then as we look down that commitment flow down, we have analytics that line up and let the managers and the leaders of each one of these levels of the organization manage to their business goals. Because if you think about a goal at the top of the enterprise or the health system, a strategic initiative, the key performance indicators that are going to help drive towards that overall goal at the top level may be very different than what a frontline manager is concerned about, and so they need tools to help manage those KPIs on the front lines. So as we continue to look at the analytics strategy, we think about kind of a 4-component or 4-variable approach between data, people, process, and technology. When we talk about data, we talk about enhancing the value of Cleveland Clinic's data assets. All of the data that's created by people or by machines, by devices in your hospital, or manually collected data from vendors, and so forth. And so then that brings us to the people. Here we talk about the people who create that information, who are either entering data manually into systems or applications, people who are entering data into EPIC, our electronic medical record, in various manners, but also the people who then are responsible for processing this information, as well as the people who are ultimately consuming the information in our enterprise dashboards and reports or through the self-service analytics. So together, the data and the people, it all comes together through a process, either standardized governed processes of collecting information, again, through EPIC or our EMR, where our teams build out specialized forms and entry points to govern that data entry, but also the process to do our ETL, create our data warehouse for reporting. And so altogether, we stand that up on a technology stack, and our goal is to create a modern analytics platform. What that looks like is what you see pictured here. This is our entire analytics platform in our enterprise information management and analytics area at Cleveland Clinic. And what we try to do here is use best-in-breed technology or software or hardware to bring to the organization the best value that we can. At the heart of our analytics platform is our enterprise data vault. And so this sits on Teradata hardware, and we extract data from EPIC, our EMR, and we warehouse it in a data vault model. And so really, this is a big journey that we've been on over the last couple years, and we're seeing great returns on. On the bottom, you can see that for our data asset management, we use Informatica for a metadata manager, and that helps to put increased data integrity and governance around the information that we have available in our data vault. On the side, you can see we have a SaaS analytics engine, and we also use Hadoop and Cloudera to store our big data from, for example, some of the e-device information that we have out of our ICU. On the left, we have our data labs, which is essentially a playground for analysts and statisticians at the local levels within our service lines to be able to go in and find new insights on their data. When that information then is certified, it can be raised to production level state and placed back into our enterprise data vault. But the top layer are analytical tools. You can see at the top, of course, we have Excel. Everybody wants, give me all the data, let me put it in Excel, I'll make a pivot chart, I'll make a pivot table. So we can't get around that. We have Excel for sure. Good, some laughs? Oh, thank you, thank you, thank you. SAP, which was our legacy reporting system. We have SQL Server, which allows some of that kind of intermediary, maybe that local to intermediary transformation of data by maybe some of our more powerful analysts who are familiar with that technology to do a little bit more transformation. And then again, if they find insights, they can bring that back to the data vault through governance. We use SAS in order to build predictive models for our predictive analytics. And then, of course, we have Tableau, which is what we're here to talk to you about today. And you can see some of the information on the right here about what our Tableau installation looks like across our health system. We have Tableau Desktop as well as an enterprise installation of Tableau Server. Okay. So that's background on Cleveland Clinic Health System and our business objectives and our analytics platform. So now what we want to do is transition to 4 use case examples of how we use this analytics platform along with Tableau at our organization. So as Joan said, the first one we want to highlight is a partnership between our centralized business intelligence department that Joan and I work for and a partnership with our Emergency Services Institute. So to understand the context, at Cleveland Clinic, our Emergency Services Institute comprises of 15 emergency departments, all using EPIC, and a module within EPIC, our EMR, called ASAP. These 15 emergency departments are spread all across Northeast Ohio, as well as locations in Florida. And so because all of our emergency departments are using the same module and the same EMR, there's a wealth of data and an accessibility to the encounter information when you come in as an ED patient that we can extract and put in our data warehouse, and then also supplement with ancillary services or ancillary data sources like a patient experience or quality or perhaps information that's coming from a vendor to help create cohorts and do some comparisons. So with that, this institute has a wealth of data, like I said, at their hands. And therefore, they have a lot of questions, right? Because when you have a lot of data, everybody wants the data, but they don't really know how to look at it, right? Does that sound familiar? Yeah, okay. So they become one of our frequent flyers of those 200 or more analytical requests per month that Joan spoke about. So overall, as a solution, we put in place partnered governance. And so what that means is that the leaders of our business intelligence area, as well as leaders of our Emergency Services Institute, get together on a monthly basis to rank and prioritize the work and the requests that are coming in so that we can provide the highest level of value in the correct order to that institute. But we can't get to everything. We have, obviously, resource constraints. So we want to give them some type of technology enablement. And that's what we did with the power of Tableau sitting on top of that analytics platform that we saw in the previous slide. So what that allows us to do is to give them the power of Tableau for self-service analytics. The local analysts are able to not only go in and mine their own emergency services data mart, but they're also then able to create dashboards and deploy them out to their leaders and their clinicians. So as we look at kind of a very high-level view of the data model that's in place, we start in the bottom right. And we have at the core our EPIC electronic medical record system, again, that all 15 of these emergency departments are on. At the core of that is our ASAP module, where all of your ED encounter information goes. And then we can supplement it with inpatient information should the patient then get admitted following their ED encounter. We stage that information in Teradata, in Oracle, and in SQL Server for various reporting needs. And then, like I said, we can blend that information together with either external files, external data sources, again, from a vendor or otherwise, or perhaps some decentralized data that other service lines or institutes in our organization are creating. One example of that would be decentralized data coming from perhaps a statistician in another area running some SAS algorithms to do predictive modeling for, say, ED throughput. So we bring that all together at a high level, and we see that the dashboards have provided value back to the Institute. We've seen examples where data has replaced anecdotal evidence or hypotheses that were coming from clinicians or people on the floor, and we'll see that in just a couple slides in one of our use cases within emergency services. We also found that the visualizations are able to help highlight and drive performance improvement. So instead of rows and rows of data in an Excel file, or maybe even your simple pivot chart in Excel, the power of the visualizations within Tableau have led to insights that we otherwise didn't think were there. And then through the deployment of the dashboards on Tableau server, we're able to have increased transparency and more comparative analysis across the 15 emergency departments, or even the clinicians who are essentially creating the information or being held accountable for the care of the patients. And as we do that and as we promote that and make it more transparent, it then promotes the friendly competition among either the emergency departments or the clinicians. So next, we want to highlight two use cases within this service line within Emergency Services Institute on two programs and dashboards that together we helped build with them. So the first is around a callback program that was instituted at the beginning of this year of 2017. And what this was about was a program by which clinicians will call a patient 1 to 2 days following their ED encounter discharge. And the purpose of the program was to basically to call them back and assess their well-being, to check in on the patient, make sure that they're still continuing with the care that was advised, make sure that they don't have any questions, say, on medications or follow-up appointments that they may need to have scheduled. That was kind of the primary focus. A secondary focus was to remind the patient to take the patient satisfaction survey that they receive via mail about a week after they have their ED encounter, so that some of the information that they then return can be more meaningful, because especially in the ED setting, we see a low return on those patient satisfaction surveys. So not only was this a great opportunity or a great program to help affect the patient care by checking in on the patient and making sure that they knew what was coming forward or after their ED encounter. But then it also helped to make some of the data that we are housing for patient satisfaction even more meaningful by hopefully raising that population size. So the current conditions of the program, the information around the program is captured in EPIC in what's called a flow sheet. And essentially, it's space in EPIC where we can track who placed the callback to the patient, what time they placed it, and then there's an area of standardized questions that they're supposed to ask, and we get those answers as well. And so the dashboard helped then leadership track the callback performance because they initially started this program and then didn't have any way to track it until we ultimately built the dashboard. So let me blow the image up a little for you guys. Okay, and we'll talk about some of the measurable impact. On the top chart, bar chart, on the left, we're starting with March, and then we're going out to September as the far most right bar. And the orange trend line represents the callback percentage, the percentage of patients who were discharged in that month that were then called back. You can see, about 3 months into this program, they're down at 24%. As we continue the tracking and ability to put in some process improvement initiatives, this particular emergency department, which is located in a city, Twinsburg, Ohio, now is up at the 99 and 100th percentile for the overall callback percentage. In the bottom left, you see our comparative analysis across the 15 emergency departments. We just broke it down to 1 month for this particular example, but you can see we have some leaders and we have some laggers. We've got 33% of our emergency departments in the month of September that surpassed our 75% callback rate. And so what the comparative analysis allows is leaders from the emergency departments that are perhaps not performing as favorably to reach out to the leaders of those that are performing favorably and then share best practices amongst those emergency departments. And what this has led to overall, when we compare April, in the bottom right-hand graph, when we compare April to September, we've seen about a 25% increase in overall callback percentage performance. So that's the bottom right. That's the cohort of all 15 emergency departments measured together. So some really good progress here, and we're hoping that we can, by sharing those best practices, bring some of those laggers in the comparative graph up towards that 75% callback goal. In our second example in emergency services, we're looking at imaging turnaround time. And this is an example of where the anecdotal hypothesis by the clinicians was then essentially disproven by the data that we were able to measure and build a dashboard around. And so the use case is that the turnaround time increases as your emergency department length of stay increases. We obviously want to get people in the emergency department, get them to their room, triage them, right, provide them the care, and then get them out. Because the longer that you have a patient in the emergency room or the department overall, you have several implications. Obviously, for the patient, it's lower patient satisfaction. You want to get in, you want to get out, you want to be able to move on with your continuum of care. Also, we have a higher rate of left before treatment. So this is where you would come in, you would start your treatment, but then because it was essentially taking so long for, say, the doctor to come back, you may decide to leave the emergency department before your care is finished, which then likely would result in a higher acuity follow-up encounter. And then, of course, increased boarding. So all of that really goes to the general throughput problem within an emergency area. So as we build up this dashboard, and I'm going to blow up the top section here, what we're looking at in this stacked bar chart is each one of the components or kind of time slots for imaging turnaround time. So from the time that your physician decided you needed an X-ray or a CT or an ultrasound, to the time that it was taken, to the time that it was read by a radiologist, to the time that then there was a final sign-off and your attending provider could come back to you and then give you clinical treatment based on that overall imaging. So that's what you're looking at in the stack bars, and each one of those are median times. The black trend line on the top is a median time of the overall turnaround time for that month. So what you can see is between January and July, there really wasn't a lot of movement in the top of these stacked bars. And now a little bit of math, so stay with me. Because each one of these stacks is a median, the line is also a median. It's interesting that there's a gap between the top of the stacked bars and the trend line. And what that highlights is that there's a pretty good number of outliers in the overall process. So the gap between the top of the stacked bars and the trend line are our outliers. So while the data didn't really support that anecdotal hypothesis that imaging was taking too long and therefore the length of stay for these patients were increasing, we did find that there were a lot of outliers. And of course, probably as you guys all know, when there are outliers, those are the ones that get talked about the most and that affect the perception the highest. So as a result, we were able to then look into the outliers, identify them, and then look at some of the performance opportunities to address those outliers. So that was an example of both the anecdotal hypothesis not being supported by the data, as well as the opportunity for the visualization to highlight an opportunity. So as we finish with the Emergency Services Institute partnership, I just leave you with this quote from one of the analysts in emergency services speaking to that partnership. And now I'll turn it back over to Joan, who's going to talk about 2 strategic initiatives at our health system.
Thank you. Thanks, Michael. So I'm going to talk about 2 different strategic initiatives. The first is going to be about care paths. As any of you that work in hospitals or medical, I think you know about care paths. A care path is, and for those of you that don't, I'll tell you, a care path is very specific, is a procedure-specific initiative to operationalize clinical workflows in a way to create best practices and very succinct guidelines in treating either patients of a certain disease type or having certain procedures. So Cleveland Clinic has quite a few care paths initiated, and they all align with national established guidelines and are centered on optimized patient care, improving outcomes, as well as leveraging IT to improve quality and reduce cost. So the overarching goal of a care path is to make it easier to consistently treat patients and to give them the best care possible. So we use the term, fact-based decision-making a lot in business intelligence, and this is kind of what care paths kind of do for the medical part. Because you create the procedures and it makes it easier for the care path to continuously be reviewed, you can measure and then improve your care quality with the emphasis on the outcomes for the patient. So care paths integrate with EPIC in a couple different ways. The first thing is the creation of the clinical care paths checklist and processes that flow into the EMR. And this is some examples I'm throwing up on the screen here. There are flow sheets, best practice advisories, order sets, medicine order sets, and all of this is put into the EMR to help clinicians stay accountable and to help identify any opportunities there may be for improvement. Secondly, then, we take that information out of the EMR and create key indicators to measure the outcomes. We either can measure the outcomes of the patients and how they are being treated and handled, and their outcomes in general for their whatever the care path is measuring, as well as just to check to make sure that all the clinicians are following the correct procedures. When you have a best practice advisory, a BPA pop up, it will let you track if the physician is following it or just dismissing it. So it's very helpful in helping to make sure on the clinician sides that the care paths that we're trying to implement to help patients are actually being followed. So one of the issues we had when trying to create reports around care paths is what I talked about earlier, is having the right report for the right people. So as we started, the people that were using the care paths and wanted data out of it were the institute chairs. These were the sponsors of the care paths, and overall, they wanted high-level data to figure out, to do some level setting and to see where we were in terms, in general, of following the care path guidelines and, in general, seeing where the outcomes stood. So as that became more and more relevant and the institute chairs use that in more and more meetings, the user group started to change of who wanted to look at information. So at that time, we began to also use Tableau quite a bit, and we realized that as our users needed more and more information, we could really use the power of Tableau to dig into the visualization and give them information to really help them affect patient care. We gave them the ability to drill into, and this is one of our first reports, that's very, very basic as you can see, but it allowed them the ability to dig into the reports at different levels. They could choose institutes, they could choose locations, they could choose specific physicians or physician groups and figure out how their outcomes were they improving, see trends, and do comparisons year over year on that. So what did we find out? So one of the first care paths that were implemented was a spine care path, very specifically around acute back pain. This was done for a number of reasons. One of the most is that the national direct and indirect costs for care of acute back pain seemed to be rising, and we didn't really have outcomes that supported all the rise in the medical costs that was coming with that type of treatment. Some of the issues that were really key was extensive imaging, x-rays, CTs, MRIs, and then as well as opiate drug prescriptions. It was kind of shown that doing both of those things for a lot of patients didn't really affect their outcome, and it did raise their cost of their care. So we wanted to try and figure out what could we do about that, and as part of our clinical care path initiative, put some checks and balances in for that. So through the use of the care path, we were able to see a 60% drop in the number of imaging orders put in for chronic back pain. Additionally, so this is a cost savings, right? And it's also a savings for patients because if you have to go get an MRI, multiple x-rays, that's time for you. That's often time and stress to try and schedule those things. So overall, it was a cost savings for the hospital and the system, and that also helped with the patients who didn't feel like they were getting treatments ordered for them that maybe weren't really helping. The second thing that we saw was a 35% drop in the number of opioid prescriptions. There's an opioid epidemic in the country, and in cities like Cleveland especially, the less number of prescriptions you can put out there for that, the better we are. So overall, we found that this also helped patient care, and it also helped drive down cost. The other care path that was one of our first is around total hip and knee replacement. There were, again, quite a few different ways we wanted to look at this. One of the biggest things that we thought were going to be an issue, and that was kind of seen nationally, was patients being discharged to home instead of to a skilled nursing facility or rehab facility. If a patient went home, they had better outcomes overall. There were less 30-day readmissions, less 90-day reoperations. So we really tried to focus on that. And we had a 46% increase since the start of our care path with the number of patients that were discharged to home instead of going to a skilled nursing facility. A lot of this was accomplished by education on the physicians and nursing side when a patient was in the hospital getting their hip or knee replacement. And through that, we were able, like I said, to have cost savings by having less nursing home days, and patients felt better overall going home and had better outcomes in general. So as I finished talking about the care path, one of the really great things is that Dr. Timothy Crone, who is the champion for care paths at the Cleveland Clinic, is also the medical director for business intelligence. So with his support and advocacy, we're able to be creative and come up with new ways of doing reports, of highlighting information. He's really receptive to that, and he also is a great believer in helping the clinicians see how this can be used as well. So he helps to push those reports out there and uses them in his own meetings to help show everyone that these have a lot of valuable information in them and that they should be utilized at all levels of the organization. So he is a real proponent and a big supporter and a real great reason why we have used Tableau in the care paths as much as we have. So one more strategic initiative I wanted to talk about is patient access, specifically about no-shows and same-day cancel patients. I think as everyone knows, that is kind of really an acute issue in the medical community. Patients, need to feel like they have the kind of care and have access to the kind of care in a timely fashion. So when patients either don't show up or call on the same day to cancel, that has a lot of effects and hinders healthcare for everybody. First of all, it negatively affects the patient who's canceling or not showing up for their appointment. Obviously, they're then not getting the care that they need for whatever the reason they made that first appointment. Secondly, it can raise the acuity of when they finally do get treatment and the way they get treatment. Typically, if they've canceled their appointments with their physicians, if they are getting worse, they're going to go to an ED. And that not only is a problem for them as they're now sicker than they were, it drives overall healthcare costs up for everybody when the ED is used in this manner. The other thing that is really a big issue is this pushes out patient care for everybody, right? If, say, appointment's canceled the same day, it's really hard to get another patient into that slot. Sometimes these are patients that are just trying to get into the clinic or get in with a provider for the first time. Those are longer appointments, and so trying to get one of those then is pushed out even farther because the hospital, the doctor looks like they're booked. When those are left open then, not only does it stop these patients from getting in at that time, it pushes out their ability to get world-class care. It then affects, of course, the physician's office. You know, they go from having what they think is a very busy full day to having a lot of open slots. That causes morale issues and productivity issues, and that overall reduces the income for the office as well. So at the Cleveland Clinic, we are only trying to decrease the number of no-shows or patient cancels by 1%. Now, 1% may not really seem like a lot, but when we have 7 million visits a year and 10% of them, say, are no-shows or same-day cancels, 1% can really make a significant impact. So overall, that is the goal for each institute. We think it's clear, it's totally doable and a reachable goal. So we're starting with that. We'll see how we'll go. So what we did about this, though, is we started to create some reports. You know, we had data, as Michael talked about, in Excel, all kinds of rows and columns of numbers. And in the end, that wasn't really helpful. So what we wanted to do is create something more visual and more easy to access. So this visualization, it has some basic counts of no-shows and cancels, patient cancels, clinic cancellations. We have some information about the reason why the cancellation is happening. We also created some trend graphs around patient age, gender, ethnicity, and then also we wanted to try and take a look at trends by days and weeks and months, just thinking there might be something in there to look at that help analyze and see if there are certain days or times that seem to have more cancels or more no-shows. We also wanted to create some geospatial data graphs around this. So what we created is these two graphs that work side by side. So what you can do is on the right-hand side here, you can see I've selected a zip code of Sheffield Lake in Ohio. You then can see the number of no-show and cancels that were at each of the various facilities that the patients in that zip code visited. So that we hope would help us maybe figure out, is there certain zip code areas of our patients? Are there certain locations that are having issues that are bigger than maybe the rest of the enterprise? And that brings us to our very specific use case around our Lorain, Ohio Family Health Center. So what they did is they started with this graph and took a look at their family health center. And the first thing they noticed is that their rate of no-shows and cancels was at 19% when the clinic overall was at 11%. So they seemed to think that maybe they had a little bit of an issue there that was greater than the rest of the enterprise. The other thing that they found is that the number one reason that people were given when they called in to cancel an appointment was transportation. They had a 38% overall rate of transportation being an issue in Lorain versus 19% overall. So we start looking at that and people start talking about, like, well, what does that mean and what can we really do about that? Is there anything we can really do about that? So we dug into the geospatial information a little bit, and we kind of worked these graphs in the opposite way. So that's the cool thing about them, is they work both ways. So instead, we chose the Lorain Family Health Center on the left-hand side, and then able to see where are the patients with the same-day cancels, and we were able to pinpoint into the chronic cancels, those that had 3 or more no-shows or cancellations. And we're able to find that 74% of them live within 10 miles of the Lorain Family Health Center. So that's a pretty tight population in a pretty small area. And overall, that area was seeing higher healthcare costs. They were seeing higher acute issues. They were seeing more patients in the EDs instead of at their physician offices. So they put a group together to try and figure out, you know, what can we do about this? Is there any kind of program or anything we can implement to try and help alleviate this problem? And we came up with a pretty creative solution. So they decided to partner with a national rideshare company, names hidden for the protect the innocent, to offer rides to patients that when they called in and told the patient service representative that they couldn't make their appointment due to transportation issues, the PSR would then offer them a ride, and they would have a driver pick the patient up, bring them to their appointment, and then they would also be able to get a ride home from their appointment. So this is a brand new initiative that we have just started. We don't really have any results yet. From what we can tell, it's kind of the first of its kind, and we're really proud and hoping that we can help improve patient care overall and help the patients that are having that hard time getting into their appointments and they're close to the facility. That's what makes it kind of a no-brainer. You know, within 10 miles, that's pretty easy to cover, and so we're hoping that will really show us some improvement in that area, so stay tuned. And with that, Michael now is going to come back and talk a little bit about our executive overview reporting and show you kind of what we're doing at that level. Michael?
Awesome. Thanks, Joan. That was a great overview of 2 of our strategic initiatives. So to close out our use case section of today's presentation, like Joan said, we want to talk about our executive operating review. And before we do that, just to revisit our institutional alignment slide. So now, Joan talked about 2 strategic initiatives at that top level of performance management. What we want to do now is go kind of even one level higher, and we're going to look at the very top level of our commitment flow down at our enterprise goals. And you'll see as we look at the dashboard that it's framed around the 5 pillars of patients first, caregivers, affordability, impact, and growth. But before we get to the dashboard, we just want to cover one topic here called strategic agenda management, which is kind of the business process and business workflow at the heart of our executive operating reviews. And what strategic agenda management is designed to do is to facilitate strategic execution of your strategic goals, of our health system's goals. And they do that by prioritizing the set of goals and KPIs that then relate to those business goals, and then help to focus in on those because they are prioritized. Based on that, it helps to align our operating units, our business units, or our medical specialties. And because we're aligned and we're all working on the same thing and towards a common goal, it helps or increases our speed to execution. And then on the caregiver side, on the employee side, it helps to build caregiver connections and engagement because we know that we're all working towards the same thing. Joan and I are working towards analytics, towards the same goal. People in the medical specialties are working towards their institute's goals, which then they're held accountable on this operating review as part of the overall strategic agenda management. And when caregivers or employees are more engaged, it's proven that they're then more productive. So the picture in the bottom right is the setting of our executive operating review, which is a monthly meeting that's held, again, in this setting. So it's a discussion around a balanced scorecard that's at the heart of this business process. And around the table are executive leaders from the health system. So it could be our COO or our CFO, our CEO, our associate chief of staff. And then the other half of the table is comprised of executive leaders from our medical specialties or from the community hospitals, kind of one at a time. So our emergency services institute executives and leaders would come in and sit at the table with our health system executive leaders and then have a discussion around the balanced scorecard, which is driven by the enterprise goals, our clinical enterprise priorities, and then they're measured, of course, on KPIs. So let's take a look at what the dashboard looks like. So again, in this monthly operating review setting for this monthly meeting, we measure the success on key performance indicators that drive the strategic agenda. As we look at the meeting helps to identify and prioritize critical goals and initiatives of that institute or of that community hospital. And not just on the KPIs, but also on performance improvement efforts that they've put in place in order to address their KPIs that may be not performing favorable to their goal. And during this meeting, they have a collaborative problem-solving session where the discussion is really focused around closing the gap as opposed to your monthly performance and being held accountable. You didn't make the target. It's a discussion on, well, what can we do in order to move us towards a more favorable state? And so some of the measurable impact of that is that it helps to align our business units to the enterprise goals based on them coming in knowing what they're going to be measured on based on that strategic agenda management. And again, we can see we're also able to then leverage best practices amongst the different service lines because the same executive leadership from the health system is sitting in all of these meetings. If someone is lagging in their performance, then the executive leadership is able to say, well, why don't you go talk to heart and vascular, or why don't you go talk to lab, right? Same measure, maybe they have some performance improvement efforts that they put in place that you can learn from. But also, there is some sense of accountability. Our leaders know what they're being measured on. They know that they're going to have to speak to what they're doing to correct poor performance or not favorable performance each month. And so there's definitely a level of accountability with that. So what we want to do here now is talk about how Tableau has kind of helped enhance this overall business process. So we take the top section of the dashboard and we look at what we like to call our focus metric banner. These are metrics that have been prioritized at the highest level to focus on out of the balanced scorecard for a particular service line. And here we're looking at emergency services. Each one of these metrics is then grouped into the pillar that they relate to. So you can see patients first, caregivers, and affordability. Through the use of filters in Tableau, we're able to set what the focus metrics are for the executive leaders. And then when we deploy this to Tableau Server, we use the power of the original view on Tableau Server to save these preset filters for the leaders of these service lines so that they don't have to waste time coming in, remembering what they're being measured on. They can just come right in and get their focus metric banner as appropriate. The next section represents the full balanced scorecard, and it represents the actual performance in the blue horizontal bars against the enterprise or the service line target, which is the orange vertical bar off to the right. We reinforce whether or not that performance is favorable or unfavorable with an indicator light, and those are the green, red, yellow, and blue check marks. And then finally, in the bottom left, we use a scatter plot to show that comparative analysis. The highlighted blue dot is the service line that you've chosen, along with all the peers kind of in the faded blue. The y-axis representing their performance, and then the x-axis representing the population. So you can look for opportunities for improvement and essentially the biggest bang for your buck. And in the bottom right, we have our trend graphs. Trends are always good. We want to know how we're doing over time. Are we improving over time, or do we need to look at maybe an initiative that we have in place that may not be as effective? So overall, this type of business process at Cleveland Clinic has been in place probably for 8 or 9 years. It continues to evolve as the executive leadership continues to see more and more value. The introduction into Tableau and some of these things like the focus metric banner are relatively new within just this year of 2017. But we do see a lot of great adoption, and we're continuing to add more and more to the report in order to lend that overall business value. So to close, we want to look at benefits and next steps. And as we all know, implementation is a journey, both implementation of a data-driven culture, as well as implementation of our hardware and our software, and in this case, of Tableau. To recap some of the benefits that we saw today, in our emergency services area, we showed a 25% increase in the overall callback rate for their callback program and how Tableau helped to identify opportunities for improvement. And then Joan talked about in our clinical care paths, how we saw in some of our care paths a 60% reduction in imaging costs, as well as a 35% reduction in opioid prescriptions, two metrics that are very relevant to today's times with both the opioid epidemic, and taking cost out of the overall healthcare delivery. One of the business goals and business objectives that Joan presented at the beginning today was a shift towards self-service. So some of the metrics that we keep track of that we think speak to that in our journey is that on Tableau Server, year over year, our published workbooks are up 146%, meaning that we're creating more content. We probably have more people creating content, which is then also evidenced by the fact that our distinct users on Tableau Server are up 54% year over year. Long-term goals, we continue to look in that self-service direction. We want to increase our data accessibility to our enterprise data vault, if you remember that depiction of our analytics platform. And as we do that, we want to certify and publish more data sources to Tableau Server to then even more promote that self-service analytics ability. As we do that, we shift towards building a power user community and create user groups in our area for best practice sharing. And then finally, which we think is also pretty unique to our organization, is that we're going to be implementing what we're labeling or calling Analyst University, which is going to be an education and training program of our analyst statisticians in our organization in order to help build their analytical skills and their business acumen overall. So thank you very much for being with us. We had a great time presenting. Thank you to Tableau for having us. Thanks to Andy for helping us with today's presentation.
Huge round of applause for Joan and Michael. We have another 5 or 6 minutes for a few questions. If you have any questions, please raise your hands. I'll come by and have you ask your question.
Yeah.
Oh, there you go. Okay.
I was like, oh, no questions.
Hi, I am a consultant analyst with a consulting firm, and we work with a lot of EPIC data, and I don't know that much about the inner workings of the EPIC system, not as much as I should. And I apologize to any EPIC people here, but it's usually a struggle to get a lot of the information out, and I was just wondering what were the challenges of doing that to get all this stuff spun up?
Sure. So since everyone is on the same EMR and the same installation across all of our hospitals, we do see some pretty good alignment of the information input. So when we're looking for a particular piece of discrete data, it generally is in the same place within the EMR. So that's kind of the first hurdle. The second piece, like you said, is extracting that information. So we extract the EPIC EMR information into our Clarity warehouse, which is kind of EPIC's reporting warehouse. And then from there, yeah, there's some work to map it appropriately into the enterprise data vault on Teradata. But our team and our department has been doing Clarity reporting for probably, I don't know, 20 years or so. So as we shift towards the enterprise data vault, there's work with our senior data architect to model that all appropriately. But because we have that core from the Clarity data model, we're able to kind of port that over. And then we use the Informatica to manage all the mappings, data integrity, and data quality along those lines.
Any other questions at this time?
Hi, I'm a data engineer and analyst for a medical group of emergency room doctors. And we get a lot of data from the hospitals that we work at, from the emergency, the EDM, the emergency department module. But we don't get a lot of the data from the inpatient, the hospital side. What value to the emergency room do you find in having access to both of those?
Sure, that's a good question. And to be totally candid, we're just starting to merge information from the emergency setting and the inpatient setting and create a larger picture. That's what we're hoping our enterprise data vault will get us to. But I think it's essentially throughput information, right? When they left the ED and then they went into your inpatient setting, how quickly were you able to move them? bed management aspects of that as well. I know that some of the analysts in our emergency area are looking at ICU care that was provided for emergency patients and what that may mean. And it's really just getting that full continuum of care to follow the patient from the time they came in the door at the hospital to the time they left, whereas historically it was really two totally separate slices. In the door at the emergency room, and then I'm done with them. And now they might be in the hospital, and now the inpatient side is done. So if you can really tie it along, you can look for those process improvements along the way.
And the ICU tie-in is really important because as a patient's in the ICU, they typically then get discharged to a regular nursing unit. And so you need to figure out, if you've got more patients coming into your ICUs from the ED, do we need more than regular nursing units to help take care of those folks when they don't need to be in the ICU anymore? So it's an aspect of the occupancy and the overall bed count in the hospital that we've been working on, trying to tie that together as well.
Okay, great point.
One last question from the lady here.
Hi there, I'm a consultant as well, and I'm currently with a pediatric hospital, and I'm in the marketing department, so it's not the clinical side, so it's kind of an interesting challenge. And I wonder, because this is such a wealth of data for somebody who is, say, marketing for all of your different service lines, checking for volume, making sure that beds are available if we're going to promote this service. Do you guys share this information with folks outside of the clinical space, and if so, how?
That's a really good question. So we do have dashboards, enterprise dashboards that share all that information that are available to really anyone at the enterprise. We don't get a lot of requests. I think that's probably an area that is untapped and could be used better. I honestly do not know of anyone in the areas using it. Right, no, that's right, yeah. I think it's still part of this whole, I think there's, like you said, kind of like a split, right? People who do the medical side feel like this is what they do, and the other folks like us who aren't feel like, oh, well, we're not doctors or clinicians, we are separate. We're not caregivers, we don't affect patient care, but everyone does, right? And if everyone works together, and I think part of our self-service analytics is gonna help that, because if there are people in those areas who have been getting reports or using data, they're gonna start raising their hands now for more information. So hopefully there is some tie-in, and as those executives in some of these strategic meetings become also accountable for helping figure out how to use that information, it'll help drive that as well. But that's a really great point, and I think a big place, a lot of health systems probably need to kind of tie it together and help bring that information together to be used effectively.
Awesome. That's all the time we have. So thank you very much for being at this session.
Thank you.
Thanks.
If you've enjoyed this presentation, please provide your feedback or not, right? And let us know how you liked it. And a huge thank you to Joan and Michael for a job well done. Thank you.